Good morning, everyone. Welcome to a webinar presentation on anaphylaxis and the role of diphenhydramine Epi and Salbutamol. This is your first webinar with us. My name is Stephanie Romano, and I'm the Education Coordinator with the Base Hospital. Presenting today, we have Christine Hardie, Regional Paramedic Educator, and Matt Davis, Local Medical Director for Education. So the way that this presentation is going to work is you're going to see a PowerPoint presentation in the background and hear the rest of us sort of talking about the PowerPoint. If you happen to have any questions throughout the presentation, feel free to go ahead and type them in the chat box or in the question box at the bottom of the control panel. Otherwise, if you have a microphone and you'd like to ask a question near the end of the presentation, you can click on the little hand icon, and I'll notice that your hand is put up, and then I can unmute you, and you can ask your question live. So once again, throughout the presentation, you can type your questions into us. We'll either answer them typing back to you, or we'll broadcast the answer so that everyone can benefit. And so without further ado, I will pass it over to Christine and Matt, and here's your presentation.
Thank you, Stephanie. Just wanted to acknowledge Dwayne Cotel, who put this presentation together. Unfortunately, he couldn't be with us today to present, so I have Christine Hardie joining me today for the presentation on anaphylaxis and the medications that are used in anaphylaxis. So some objectives for today's webinar. First off, just describing the pathophysiology of an allergic reaction versus anaphylaxis. In doing so, we'll also talk about some of the medications used for allergic reactions and anaphylaxis, including diphenhydramine or Benadryl, epinephrine, and salbutamol, Ventolin. We'll also go over how to appropriately apply the moderate to severe allergic reaction medical directive, and we'll go through this through a variety of patient care scenarios during the presentation. We'll also touch on how anaphylaxis may cause cardiac arrest and its possible treatments in that situation. So what is an allergic reaction? An allergic reaction is an over-response of the immune system. So what happens is a foreign protein, which is known as an antigen, enters the body. And this foreign protein is recognized by the body as being something that doesn't belong there. And as a result, the body hosts or puts forth a defense against that foreign antigen. And these foreign proteins can enter the body through inhalation. You can think of seasonal allergies, ingestion, so certain medications or foods, injections, and absorption. So again, mainly through medication routes. When allergic reaction occurs, histamine is secreted from mast cells. And histamine is responsible for bronchoconstriction, increased GI motility, and edema within the GI system. It can cause vasodilation and increased gastric acids. So as this histamine is released, you get that allergic reaction response, be it from urticaria to wheezing to hypotension. So what's the difference between an allergic reaction and anaphylaxis? An allergic reaction is usually a mild, localized kind of response. You can think of this as your seasonal allergies. So someone, this time of year when trees start pollinating, ragweed season, you get those itchy, watery eyes. Some people develop some hives, localized hives, for instance, to, or some localized swelling, for instance, to an insect sting, watery eyes, runny nose. So very mild symptoms. On the other hand, anaphylaxis is a more systemic response to the foreign antigen. So in addition to the cutaneous findings that you get in an allergic reaction, you will also see things affecting other organ systems with anaphylaxis. So for instance, with the respiratory system, you may find that a patient has some wheezing or stridor due to airway edema. You may be hypotensive due to systemic vasodilation. They may get some chest tightness due to the bronchoconstriction. And you also see edema, both at the lips, the tongue, the skin itself. And anaphylaxis is very rapid in onset, and it can be very deadly to some and can lead to cardiac arrest. So again, a mild allergic reaction is an antigen-antibody reaction. It's not life-threatening. Again, this is someone who has allergies to cats or dogs. Their presentation may vary from sneezing to getting some watery eyes, runny eyes, kind of generalized pruritus or itching. And oftentimes these patients will just take an antihistamine such as Benadryl, or an over-the-counter allergy medication such as Claritin to help with their symptoms. Once the allergen is removed from the patient, or the patient removes themselves from the allergen, the symptoms tend to resolve over the course of an hours to a day. So this is a self-limiting reaction. And again, this is treated with antihistamines to help with the symptoms. On the other hand, a severe reaction is a more severe systemic response to that antigen. It can be rapid in onset and can be life-threatening for people. Oftentimes it can go unrecognized, and oftentimes treatment can be delayed. So it's important to kind of recognize these cases as soon as possible. And the reason for this is that they have an extreme risk of airway compromise, including airway edema, and more so circulatory collapse. They become very hypotensive, have a decreased LOC, can be pre-syncopal or syncopal with this. Again, it's a multiple system response. So not only is it your cutaneous symptoms, but you have other organ systems involved, including the respiratory system, your wheezing, your difficulty breathing, stridor, airway edema, your cardiovascular system, so that results in the hypotension from the systemic vasodilation caused by the histamine release. GI can cause severe abdominal pain due to increased edema within the GI system, the intestines. And it can also result in some CNS findings such as decreased level of consciousness, and this is due to the hypoperfusion of the brain due to vasodilation. Again, it must be treated aggressively for patient survival. And the silver bullet for anaphylaxis is epinephrine. There's very few silver bullets in medicine, but this is the main treatment for it. Without IM epinephrine or IV epinephrine in the hospital setting, these patients can deteriorate quickly and die.
A trend that we're seeing within the region is the failure to appreciate the associated signs and symptoms with anaphylaxis. So one of the take-home points we'd like to stress today is that if you have a patient with a potential exposure to an allergen, take the symptoms and the signs they're presenting with, put the picture together, and treat the patient with epinephrine.
Again, with a severe reaction or anaphylaxis, these patients can deteriorate quite quickly. So within minutes to hours of coming into contact with that allergen, they can deteriorate and it can lead to death. Again, it can be under-recognized, and the reason for this is not all anaphylactic reactions have cutaneous symptoms. The majority do. 90% of your patients that have anaphylaxis will have some sort of cutaneous symptoms, be it hives, edema, angioedema, but not all do. So, keep in mind, allergen plus systemic compromise, be it respiratory, cardiovascular, equals anaphylaxis. Again, the goal is early recognition of anaphylaxis because the treatment is epinephrine. And this medication helps prevent the respiratory and cardiovascular collapse, which can lead to death. So now just a case study here. So you're called to see a patient, 35-year-old male, chief complaint is hives. He says, he's possibly been exposed to environmental allergen. He says he does have some seasonal allergies, and he was out working in the field baling some hay, and he started to get itchy eyes, runny nose, and some hives on his torso. He says he does have these seasonal allergies, but has never had it this bad, and calls EMS because he's a little freaked out by it. So upon arrival, you do your first set of vitals. You see that his heart rate's 84, respiratory rate 20, blood pressure is slightly hypertensive, 140 on 80. He's satting 98% with a temperature of 36.7. Note from your general assessment, he looks okay. You do notice some hives to the chest, the arms, a little bit on the neck. He's got some watery eyes. Listen to the chest, and he's got no wheezing, no audible stridor. So you decide that this is, probably most likely a minor allergic reaction. On a transport, when you load him onto the ambulance, he starts saying that he's feeling nauseated from the motion in the ambulance. You redo your vitals, they're unchanged, and there's no other changes in this condition.
All right, so with that, Matt, I'm going to launch our first poll question. So the first poll question is up there now. It says, does this patient qualify for diphenhydramine? So you're answering yes or no. And I should say that anyone who's watching the webinar on their cell phone or iPad, sometimes the app won't let you answer these poll questions. So if that's the case, just go ahead and type your answer to me in the question or chat box, and I'll record them for you. So we're just waiting on a couple more people to answer, and then I will close that and let you know what the results are. All right, so we're sitting at 94% saying yes. The patient does qualify for diphenhydramine.
And they do. That's definitely a good treatment option. So one way to think about it a little more simply is you think about, we'll talk about it later, but diphenhydramine, it dries things up. So it's going to alleviate the watery eyes, the runny nose, that type of thing, and generally remove the hives. So if you can think of it on that simple basis, yes.
Perfect. So that, sorry, Christine. That brings us to our next question, which is kind of self-explanatory. Will you administer diphenhydramine to this patient? And I can imagine their answers will be 100% yes.
Everyone should say yes now.
Yeah. I'm just waiting on a couple more people. And that's exactly what I'm seeing. So we're at 70% of the people are voting, and I've got 100% yes. So good job. All right, back to you guys.
So in terms of case management, Christine, how would you manage this patient in the pre-hospital setting?
Well, as we do regularly, oxygen, cardiac monitor, and vital signs. So it's reasonable to administer Benadryl to this patient without any contraindications, which is just an allergy or sensitivity to Benadryl, which is rare. 50 milligrams IV or IM is adequate. And IM, we had a poll question that came up regarding the choice of route of administration, and either IV or IM are both reasonable options. IV access, yes or no in this patient. If you choose to just administer IM, that's acceptable. And then you're going to monitor this patient for progression towards anaphylaxis or improvement of their signs and symptoms. So again, the symptoms we'd be looking for are more full circulatory systems, so say some wheezing or some shortness of breath or angioedema, swelling of the lips. And don't be afraid to associate any of those findings with anaphylaxis.
Now we're going to talk a little bit about the pharmacology of Benadryl. It is a H1 blocker, and H1 is histamine. So what this does, it prevents histamine from binding to its receptor site. When histamine binds to its receptor site, it causes the findings of an allergic reaction, such as the watery eyes, the hives on the skin, the facial or body flushing. So again, this is used to minimize the signs and symptoms of an allergic reaction. The thing about Benadryl is it has some anticholinergic properties, so similar to Gravel, which also has anticholinergic properties. So some of the side effects from Benadryl include dry mouth. Sometimes they can get, with excess dose, they can get sedated, confused, and agitated. In overdoses, can cause an increased temperature. So kind of the side effects are along the spectrum of its anticholinergic properties. So again, it's used to relieve itching and hives. And it's important to remember that Benadryl has no role in relieving upper or lower airway edema. So in terms of anaphylaxis, again, this is not the go-to medication. It does not prevent or treat hypotension because it does not release the histamine release from mast cells or basophils. So what it does is it blocks the receptors that this histamine works at, but does not actually inhibit the release. And that's where epinephrine comes in. So in terms of onset, from IM Benadryl, it's about 15 to 30 minutes, and of course the IV route is going to be quicker because it's absorbed much quicker through IV than IM. It lasts about 4 to 6 hours in the body, therefore we can dose it every 4 to 6 hours in the hospital. And again, the side effects mainly related to its anticholinergic properties. Again, allergy to this medication is very rare. And it's important to remember that this medication is designed to relieve the symptoms of pruritus, meaning itchy, and hives. It has no role in treating hypotension or edema in terms of the airway edema, bronchoconstriction. So again, it's administered through IM or IV injection and does not need to be diluted and given. In terms of calculating the dosing for it, if the patient is less than 25 kilograms, then they do not qualify for Benadryl. Between 25 and 49 kilos, it would be a 25 milligram dose, IV or IM, and 50 kilograms or greater, they could receive the maximum dose of 50 milligrams IV or IM. And again, the same information there that as seen in your handbook and in the medical directives.
And to note, the maximum number of doses is 1.
So moving along to another case here to kind of go over some differences between allergic reactions and anaphylaxis. You're called to see a 21-year-old female patient who has some menstrual cramps, and she took 2 Aleve for pain. About half hour after taking the medication, she noticed that her skin was getting red, she felt flush, and she noticed some hives to her neck and torso. She had some Benadryl at home and decided she would try to take some of this to see if that helped with her symptoms. And she did this about 10 minutes prior to calling EMS. And when you get there, she does state that she's under investigation for an allergy to NSAIDs, and what she failed to realize that Aleve, which is naproxen, is in fact an NSAID. She was given an EpiPen by her allergist. She has it, but she did not use it here today. So when you get there, you do your first set of vitals. You notice the heart rate is 63 with a respiratory rate of 20. Blood pressure is 149 on 88, and SATs are 98%. Temperature is 37, and she is GCS 15. Auscultating the chest, you hear no wheezes, no audible stridor. So you decide that there's no airway compromise in this patient. You do notice, however, that the patient does have hives throughout her body, and she is quite itchy with these hives.
All right, so here's our next poll question. Does this patient meet the conditions for diphenhydramine? Answer yes or no. And while we're answering this, Matt, there's a question that's come through looking for your opinion on whether a patch should, or if it does come through for a patient weighing less than 25 kilos for diphenhydramine. What's your take on whether you would give that order or not?
So if a patient is less than 25 kilograms, the general consensus is not to patch for a order for diphenhydramine or Benadryl. Reason being, again, very rare to have severe allergic reactions in these patients that are very small. There's no real benefit for the medication in the children, based on the literature. So the safety of it in terms of the medical directive, it was decided by the medical directors throughout Ontario that Benadryl would have no role or proven efficacy in these children under 25 kilograms.
Great, thanks, Matt. So the results of the poll are just shown. We've got 91% saying yes, the patient meets the conditions for diphenhydramine, and 9% say no.
Okay. Is there a second poll question after this one?
There is, with regards to Epi.
Okay. So this patient has already self-administered Benadryl, 50 milligrams, and we're going to take her word at that. So we would not re-administer the Benadryl. She does, however, meet the indications for it, but we're not going to give a second dose. And we alluded to that fact previous, because of its anticholinergic effects, we wouldn't want to combine and give her a total of 100 milligrams. There could be some side effects from that.
Good.
So I guess the next poll question.
Yeah, it's up there now. For the same patient, would you administer Epi? And it looks like we're leaning towards, we're not leaning, 100% say no.
Okay, excellent. So no, this patient at this time does not fit the indications for epinephrine. We're not seeing any systemic involvement. So our chest sounds were clear when we auscultated. Our blood pressure is normal tensive. Those are the two main things we'd be looking for. If we started to have some complaints of shortness of breath and auscultated and heard wheezes, then yes, we're starting to get systemic involvement. But at this time, no. Again, we would monitor her en route to the hospital and go from there.
So in terms of this case, Christine, how would you manage it in the field?
So the same way we just said, we'd confirm that she's taken her Benadryl, document that on our ACR, oxygen, cardiac monitor, and vital signs. I'd be repeating the vital signs and asking her about any other complaints associated with the exposure. IV access, yes or no. The actual potential need for fluid administration, that would be probably not at this time. And again, if the patient does deteriorate or we expect her to, we might want to start an IV. Epinephrine and a fluid bolus if required en route.
And guess what happens? En route, her condition begins to change. She now tells you that she has an itchy throat. It's starting to feel tight on her. You notice that her work of breathing has increased, and you auscultate the chest, and you notice that she has diffuse wheezes in both lung fields. She starts saying that her tongue is starting to feel a bit swollen as well at this time. You do a repeat set of vitals, and then you notice that her heart rate is 56, her respiratory rate is now increased to 40, but she's hypotensive at a blood pressure of 80/60 with SATs of 93%.
Okay, so definitely at this point we're going to be making some different choices. Most likely the first thing we're going to hear from her is that she's feeling short of breath and having the scratchiness in her throat. And we're going to look at the airway and auscultate. Absolutely, this patient meets the conditions just based on that alone. We throw in her vital signs, and we definitely have a case for epinephrine.
Okay, so I agree with you. This is anaphylaxis at this point. She's hypotensive, pressure of 80/60. We have a known allergen exposure, which is the Aleve, which is an NSAID, and she has respiratory symptoms as well as the cutaneous symptoms. So she does qualify for IM epinephrine. So in terms of the pharmacology of epinephrine, it directly stimulates alpha receptors as well as beta 1 and 2. So alpha causes the peripheral vasoconstriction to help with the hypotension. So histamine is released, it causes vasodilation. Epinephrine would counteract that. It causes the clamping down of the blood vessels to help increase the blood pressure. In terms of the beta effects, epinephrine has an effect on the beta receptors within the heart. So it's going to cause increased inotropy and chronotropy, meaning the heart rate is going to increase as well as squeeze better to get a better cardiac output. The beta 2 effects causes vasodilation, bronchodilation within the respiratory system to help with some of the bronchoconstriction. So again, this is the first choice of drug for anaphylaxis. As soon as anaphylaxis is recognized, this drug needs to be given because these patients can deteriorate quite quickly.
So this question came up during research this year at numerous times. So, for example, if this patient were just complaining of wheezes and we didn't have the hypotension associated with it, would we be working towards administering epinephrine, or would we just choose to start Ventolin?
So in that case, I mean, this is the silver bullet for anaphylaxis. Epinephrine causes bronchodilation. That's the beta 2 effect that it has. So this should be given first. Yes, Ventolin has has beta effects as well, but epinephrine is going to treat your hypotension as well as your bronchoconstriction. So this should be given first. It's the life-saving medication, where Ventolin is not the life-saving medication in this case. So again, epinephrine increases the force of contraction, meaning inotropy. It increases the heart rate to get a better cardiac output, which is known as chronotropy. It has some effects against histamine, so it actually helps reduce the release of histamine from the mast cells and will cause an increase in the blood pressure. Again, absorption is quick, within 5 minutes when it's given IM, and the duration is approximately 4 hours in total. We had a question come through about preferential route of IM epinephrine versus sub-Q epinephrine. And the HA guidelines and through numerous research studies show that IM absorption is much quicker than subcutaneous absorption. So the correct route for it would be IM and not subcutaneous. Ideally, it goes in the vastus lateralis muscle, so the quadricep of the thigh. That's where it's going to get the most absorption from. But if you can't access that area, then definitely deltoid would work as well. So in terms of the side effects of epinephrine, again, this is adrenaline, so it can cause, you think of a huge adrenaline rush, so they can get a headache, they can get nauseated from it, kind of get vertigos, they're very restless, and then when you start to see the effects that it has on the heart, so increased heart rate, and can sometimes cause dysrhythmias in patients. Again, from an IM standpoint, dysrhythmias would be very, very, very rare kind of case report. More dysrhythmias when epinephrine is given through the IV route. Again, allergy to epinephrine, extremely rare. We all produce epinephrine within the body, so if someone's allergic to epinephrine, it's more likely they're allergic to something in the suspension that it's made in. Again, it's given through an IM injection as opposed to subcutaneous, and this is a life-saving medication.
So this is another example of this question came through Ask Mac. So you've administered this patient epinephrine, and now she's complaining of nausea. So we've given her 50 milligrams of Benadryl at the beginning of the call. We've now administered epinephrine, and she's nauseous, possibly vomiting. Should we administer Gravel?
So Gravel would be contraindicated in this case, and again, the reason going back to both medications have anticholinergic properties. So by giving the dose of Gravel, again, you're going to increase the anticholinergic properties of these two medications, causing unwanted side effects. Gravel is not a life-saving medication. It's a symptom-relieving medication. So in terms of using these two medications together, the side effects outweigh any of the benefits. So it should not be given if the patient has nausea or vomiting.
Okay, and we had one more question come in about a patient who had self-administered Benadryl. How long should we wait? So if they gave themselves Benadryl, say 2 hours ago, can we administer it then?
So again, Benadryl, going back to the slide on its pharmacological properties, the duration is 4 to 6 hours. So the next dose of Benadryl would have to be no sooner than 4 hours. So again, even in the hospital, if a dose of Benadryl is given, we wait 4 hours before a second dose is given. So in terms of calculating the dosing for epinephrine, again, you're going to round to the closest 0.05 milligrams, and the dose is 0.01 milligrams per kilogram. Again, you're going to only administer it IM, and the maximum amount of doses is 1 dose. Now, you can give a second dose if you do patch in for it, and reasons for patching in for a second dose would be long transport times, so the patient is beginning to deteriorate after their first dosing, or again a patient who you give the IM 1 dose, symptoms improve, and then they start coming back again, and that would be an indication to patch for a second dose of IM epinephrine. So again, the maximum single dose for a patient is 0.5 milligrams. Again, we're going to base it on their weight. And in terms of the pediatric patients, the formula for calculating the weight is 2 times the patient's age plus 10 kilos. Or you can ask a parent what the known weight of the child is. And again, in adults, you can estimate their weight based on the eyeballing them, or you can ask them how much they weigh. And again, if additional epinephrine is needed, second dose of patch is required to the base hospital physician. And again, just a slide from the medical directives outlining the exact same information based on your weight and route of administration versus the auto-injectors versus the IM. So again, anaphylaxis, this presentation is variable. Again, patients can have bronchoconstriction, and this can cause wheezing in the lung fields. In this case, first medication is IM epinephrine, then consider giving Ventolin. Again, epinephrine has bronchodilatory properties, as does Ventolin, but the true silver bullet is going to be the IM in this case. Once the IM is given, then absolutely 100% start administering Ventolin to help with the respiratory symptoms. Less than 25 kilos, the dose is 600 mics by the meter dose inhaler, or 2.5 milligrams nebulized. And again, greater than 25 kilos, it's 800 mics or 5 milligrams nebulized. Maximum amount of doses that can be given in this case are 3 doses with an interval of 5 to 15 minutes as needed for the patient. So again, Ventolin is classified as a bronchodilator, and this is based on its beta-2 receptor agnostic properties. Again, it's the first choice of drug for bronchoconstriction and wheezing in terms of your asthmatics, but in terms of anaphylaxis, your first choice is going to be IM epinephrine followed by Ventolin. Causes smooth muscle relaxation to the bronchioles, helping with the wheezing and bronchoconstriction, and again, can be used in anaphylaxis when wheezing is present. Has a fairly quick onset of 8 to 10 minutes by the inhaled route, lasts for about 3 to 4 hours. Again, side effects mainly related to its beta properties of tachycardia, dizziness. It can cause dizziness, hypertension, muscle cramps. The reason why muscle cramps occur in patients is because it can cause hypokalemia or decreased potassium, leading to muscle cramps. Again, allergy to Ventolin is very rare. It's probably more something in the suspension that the patient would be allergic to. It can be administered by meter dose inhaler, nebulization, and in the hospital setting, in severe cases of bronchoconstriction, it can be administered through the IV route. However, the evidence behind IV Ventolin is poor at best and is very, very rarely used. Again, just the slide from the medical directives in the handbook outlining the dosing for Ventolin.
So the en-route management of this patient, again, just to review, included the administration of epinephrine. If you're IV certified, you're going to start an IV fluid bolus the patient if the lungs are clear, and administer Ventolin.
So again, this patient is hypotensive, so the epinephrine is going to cause peripheral vasoconstriction to clamp down on those blood vessels. The IV fluids, they're hypotensive, blood pressure was 80, systolic pressure, was 80, and the IV fluids, so you're going to fill up the tank with fluids, and again, Ventolin to help with the bronchoconstriction. So next case, now we're progressing through the spectrum. The 25-year-old male, VSA after a possible ingestion of peanuts. Bystanders said he was eating some cookies and potentially came into contact with some nuts in these cookies. When you get there, you notice that he is just swollen all over. He's got urticaria on the chest, his face is swollen, his arms, neck, everything is swollen on the patient, and he is wearing a medical alert bracelet which says that he is allergic to peanuts. So in terms of this patient, Christine, would they be administered IM epinephrine?
Absolutely. The first priorities on this call are CPR and putting the pads on the patient. We want to do that right where we are. We don't need to be moving the patient unless it's unsafe for CPR or putting the pads on. So again, CPR, pads, analyze the patient's rhythm, and at this time you need to be drawing up your epinephrine for IM administration. We have a poll question.
Yep. You know, lots of poll question here. The question is, does this patient also need the conditions for diphenhydramine? All right, so we're sitting at 80% say no and 20% say yes.
Okay, so the question was, should this patient receive?
Should this patient receive Benadryl? So
Benadryl.
BSA
Right.
patient, should they receive Benadryl? 80% say no, they do not need Benadryl. And
Okay, so at this point in the cardiac arrest, absolutely not. Your priority is CPR, analyzing the rhythm once, and administering the IM epinephrine.
Perfect. So with that, I'll let you guys go on to the management and skip the other poll.
so if this patient, it's ROS, so they get return of spontaneous circulation, the question that is often asked is, would this patient benefit from Benadryl at this point?
Oh, so we have a ROSC. No, the priorities for this patient are the ROSC management. So depending on where we are in the situation, we definitely want to be leaving the residence, managing the patient according to your BLS, elevating the head, transporting, initiating an IV if possible, and monitoring blood pressure and vital signs, as well as making sure there's a pulse for the remainder of the call. BVM ventilation may be required. If there is some difficulty with the BVM ventilation, it's quite possible you could use some Ventolin treatment via your BVM, but no, you're not going to administer Benadryl to this patient. The likelihood this patient is also a GCS that's unaltered is probably really low as well. There will be no benefit for this patient.
Agree 100%. So and this is a sick patient. This is an unstable patient. You know, as you'll know from your cardiac arrest, a lot is going on. A lot needs to be done. These are patients that need to get to the hospital quickly. Benadryl has no role in post-BSA care in terms of anaphylactic patients. Again, Benadryl is a symptom relief medication. It's not going to treat the underlying cause of the patient's cardiac arrest, which is hypotension, hypoxemia secondary to bronchoconstriction or upper airway edema. So do not bother giving Benadryl in these patients. You're going to have a lot more to do, more things that are needed other than Benadryl in terms of caring for this patient. So again, in terms of the management for this patient, Christine went over that. Your first thing is CPR. That's what saves lives. CPR, you want to attach the defib pads as soon as you can to analyze the patient to get a rhythm analysis. You're going to treat the patient accordingly to that rhythm analysis, shock versus no shock. In most anaphylaxis cases, the patient is going to be in a PEA arrest. Therefore, you know, thinking of it as arrest secondary to hypoxemia due to airway compromise or severe hypotension related to the peripheral vasodilation. Again, IM epinephrine is indicated in these patients, but the mainstay is getting a rhythm analysis, getting CPR done and a rhythm analysis. So if they're in defib arrest, do not delay your defibrillation for IM epinephrine. Again, very rare for a patient to be in a defib arrest from this presentation. And again, next, you're going to be managing the airway because oftentimes they do have some airway compromise. So again, pretty much just a summary of the cardiac arrest. We can give IM epinephrine to those who have anaphylaxis and become VSA. Again, do not delay defibrillation for that. Just in summary, you're going to give 0.01 milligrams per kilogram, round to the closest 0.05 with a maximum single dose of 0.5 milligrams. And this is going to be given through the IM route.
So a question came in, Matt. The scenario is an ECP crew has arrived on scene to find a patient VSA anaphylaxis. So IM epinephrine is given immediately because they haven't got an IV started. So should they wait an additional 4 minutes after they've administered the IM epi, or should they administer epinephrine IV immediately?
So if an IV is established and you're running your medical cardiac arrest protocol where IV epinephrine is given, then you're giving epinephrine to this patient. It's going to act for the peripheral vasodilation to cause constriction. It's going to have the same effects on the respiratory system, causing bronchodilation. So if the epinephrine is given IV, then there's no need to give the epinephrine IM. In terms of if you're given, you're trying to establish the IV, your partner gives the IM epinephrine, would you need to wait the 4 minutes? No, go ahead and give the IV epinephrine as you would with your medical cardiac arrest protocol.
And that's a good point as well, that if you do have the IV established and you've administered the IM or the IV epinephrine, there's no need to go ahead and do the reverse again with the IM injection. That's
correct. So I mean, IM is a quick route to get the epinephrine into the patient. So if IV start is delayed or having a difficult time getting the IV, absolutely give the epinephrine IM. But if it's a quick and easy IV that is established, then you follow your cardiac arrest protocol and give IV epinephrine for the patient.
Okay. So keep your questions coming. These are all good questions. A lot of them haven't been acknowledged on Ask Mac as of yet.
Another question that's come through on Ask Mac is, if Epi is given, the patient has no ROSC, the arrest is unwitnessed, and by the third analysis, no shock is given, is it acceptable to patch for TOR, or is the TOR contraindicated due to the arrest being of non-cardiac origin? And what has the teaching been surrounding this?
No, we're not going to TOR this patient. So if you are still on scene after your third analysis or your third epinephrine, then you're not going to be calling for a pronouncement or a termination of resuscitation. On the other side of that, another Ask Mac question a little while ago asked the question, is this considered an unusual circumstance? Can we leave the scene after our first no shock indicated? The answer to that is yes. So if you choose to leave the scene after your first no shock indicated, go ahead and do so, or stay on scene for the entire cardiac arrest directive and then transport without calling for a termination or pronouncement.
And the answer, as eloquently explained by Christine, is presented on your screen there. So yes, this patient does not qualify for a TOR. Follow the medical cardiac arrest medical directive and transport when the directive is complete. Or if you decide that this is an unusual circumstance, then absolutely after your first analysis, transport the patient. Either decision is acceptable. So what happens to the severe allergic reaction or anaphylactic patient once you get them to the emergency department? So once the patient gets to the emergency department, this is a sick patient. Oftentimes they're a CTAS-1 or CTAS-2 for the, not the anaphylactic, but the severe allergic reaction. Once they're in the emergency department, we're going to continue basically with the same kind of care that goes on pre-hospital. We're going to give them IV fluids. We're going to fill up the tank. We're going to give IM epinephrine. If they've received one dose, we'll probably give a second dose if they are still showing signs of anaphylaxis. After that second dose, if they still have signs of anaphylaxis, we recognize this patient is super sick and is in potential pre-arrest situation. So this is a patient who we're going to start actually administering 1 in 10,000 IV epinephrine on through an infusion, a slow infusion. Again, these patients can be an airway nightmare, so we're calling for backup. These are patients that often need to be brought for airways. They may need a surgical airway if there's a lot of upper airway edema. So these are the kind of patients that increase sphincter tone in the emergency department. Steroids, in the acute setting, we give steroids, usually IV steroids. They don't have a role in the acute management of the anaphylaxis. This is more to prevent the later aspects of anaphylaxis, that second reaction that patients can sometimes experience. So they are given up front, but again, we're not using those medications to treat them presently. That's for more down the road to start suppressing that immune system. There's not a lot of evidence out there, may give an H2 blocker, so something like ranitidine, which is known as Zantac. Evidence out there isn't that great, so some physicians may give that, some may not. in terms of observation for these patients, you know, the super sick patients that need airway management, they're going to be admitted to the hospital. These are patients who are going to go to the ICU. For those with, you know, a severe reaction who we give IM epinephrine to, but, you know, things start to settle down, they've gotten their steroids, they've gotten Benadryl. These are patients that we're going to keep in the emergency department and watch, because they can, you know, develop a secondary biphasic reaction. Hopefully not, and that's why we give the steroids. So these are patients that we keep a close eye on. If they do remain stable and continue to head in the right direction, they will be discharged with instructions of when to return. If they do not already have an epinephrine pen, then we will prescribe an epinephrine pen to them. We'll also prescribe them a dose of prednisone, so steroids to take over the next 5 to 7 days to help suppress that immune system. We'll also instruct them to take an antihistamine such as Benadryl or Claritin over the next 48 to 72 hours. So in conclusion, cannot stress enough, in an anaphylactic reaction, epinephrine is the first drug to be administered. So anaphylaxis, again, is when you have systemic symptoms of an allergic reaction involving multiple organ systems. So cutaneous findings plus respiratory symptoms, or cutaneous findings plus cardiovascular findings such as hypotension, and has to be in the known exposure to, or potential exposure to, a known allergen. Again, diphenhydramine can be utilized for allergic reactions. Again, secondary for anaphylaxis. These are, can be given. It's going to help with some of the symptom relief, but not going to solve the underlying cause of anaphylaxis. Salbutamol or Ventolin can be utilized in an anaphylactic or allergic reaction when wheezing is present. But again, in an anaphylactic reaction, IM epinephrine is your first go-to medication. That's going to have a great effect on the bronchoconstriction. Again, Ventolin can be used secondarily to help with that bronchoconstriction.
So do we have any more questions coming through? We can wait a couple minutes, and well, a minute or two, and see if anyone wants to put their hand up.
Yeah, so if anyone does have a microphone on their computer and you want to ask a question live, there's a hand icon on your control panel, and if you click on that, then I can see that you've raised your hand and I can unmute you and you can ask live. So if you want to do that, go ahead and try it. I do have one from John Smith. Let me unmute you, John. John, do you have a question for us? So sometimes people click on that hand mistakenly. Anybody else want to raise their hand and ask a question?
Or type in.
I'm not seeing anything yet. There have been a couple good jobs from people coming through in the chat line, so well done, Christine and Matt.
We paid them.
I do want to point out we have a couple other webinars coming up. We've got a stroke update on May 30th. You'll see the flyer for that coming out shortly. May 30th from 1 to 3 p.m. Again, stroke update. Early June, we should have another webinar on summertime illness, so something else that might be interesting to the group. Let me just have a quick look. I do have a couple questions coming through. Okay, so here's a question for you, Matt. Can we patch for unknown allergen scenarios for someone presenting with symptoms of anaphylaxis? So I would imagine the case is a patient is presenting with signs and symptoms of anaphylaxis, but there's no probable allergen exposure, as would be required in the directive.
Again, that would be, if there's no other explanation as to why this patient is hypotensive and wheezing, then you got to think of your differential. Is this wheezing and hypotension? Is it because the patient is septic, has underlying COPD, and has a pneumonia now, which is, they're septic, so they're hypotensive, they're wheezing because they've got pneumonia and underlying lung disease. So again, you need to, look at the patient in front of you and try to put the pieces of the puzzle together. If things aren't adding up, this is a young, healthy person who, has no medical conditions, suddenly becomes hypotensive and is wheezing, has some hives but says, no, I'm not allergic to anything, by all means, that would be an indication to patch and speak with a physician. That would be an unusual circumstance. You can always patch in. We're happy to talk with you in those cases.
Perfect. I do have another one, just emphasizing the ideal practices of if you're administering Benadryl and Epi-IM to use opposite shoulders, opposite arms. What's your take on that, Matt?
So in terms of using opposite arms for IM injections, I mean, we've all had our vaccinations or IM medications, and it hurts when you get it. And the bigger the load of medication given in the muscle, the more painful it is. So I mean, is it the end of the world to give it in the same shoulder? No, it's not, for patient comfort, and can be given in separate deltoids.
Great. And I think the last one up here, talking about that anaphylaxis VSA patient that you had that actually had a ROSC. The question is related to the value of a blood sugar reading post-ROSC. So should we go ahead and take a blood sugar on the ROSC patient?
So in this case, there's no value in getting a blood sugar on this patient. Again, patients who have experienced cardiac arrest, we know that the glucometry readings are not an accurate representation of exactly what's going on in the body itself. We would not act on high readings or low readings in these patients in the pre-hospital setting. This patient has received epinephrine, so oftentimes their blood sugar will be a bit on the higher side afterwards. But again, if you're looking for a low glucose, it's more likely related to the fact that they've been VSA for some period, and the giving of dextrose or glucagon in these patients to increase the glucose is more harmful than beneficial. You're giving a large load of a high osmolarity load, which has been shown to cause problems in terms of neurological recovery in these patients. So getting a blood glucose on these patients would be of no benefit.
Great, thanks, Matt. That seems to be all the questions that I have on my end. So if I can get you, Matt, to just show the reference slide quickly, as I thank both Matt and Christine again for the presentation. If anyone has any questions or any follow-up comments, then feel free to send them to any of your educators or myself, and we'd be happy to address them. Otherwise, the recording will be available on our website soon. And once again, thank you for attending, and hopefully we'll see you in a couple weeks for the stroke update. Take care, everyone.